Okay, now what we want to spend a bit of time on is discussing some of the general characteristics of some of the more common cancers, and we'll try to apply some of what we've been learning to these common cancers and get a better understanding of how some of these are likely to occur and what things we might be able to do to prevent them, and what some of the common treatment plans are for them with the knowledge and the research that we have at hand at this point. So the first one we're going to talk about is lung cancer. So lung cancer is sometimes also called lung carcinoma. And it's the most diagnosed and deadliest of all cancers across all populations. In about 2 million new cases were made in 2020. And it's most common to begin or be diagnosed in the 40 to 50 year age group. And although the average diagnosis is closer to 70 years of age, it was a rare cancer before smoking was common. More than 80% of lung cancers are associated with smoking, and the remainder, that 20%, is by exposure to harmful substances like asbestos or genetic mutations. So for example, a population that would have been exposed to asbestos would be miners or installers of asbestos in homes and that sort of thing is where that would come from. For all Canadians, lung cancer is the most common cancer diagnosed. For breaking it down into males and females, it's number 2 for males and number 2 for females. And we'll be talking a little bit later about number 1 for each of those. So when we look at the causes, for cancer, genetic abnormalities to the DNA of lungs is typically seen in more than half the cases, and that's determined by exposure to smoke primarily. So basically, it can be random, but most commonly it's induced by airborne toxins. So when we look at the cause for cancer, genetic or let's take that out of there. Abnormality is to the cells of the lungs. To cells of the lungs. And this, like I mentioned, can sometimes be random, but more typically it's going to be because of chronic exposure to airborne toxins from chronic exposure to most often smoke. So the carcinogenic chemicals that are loaded up into a cigarette of whatever source, whether tobacco or marijuana now, we have to be aware of these chemicals that are going to increase the risk for mutation. And when that mutation occurs, it's going to allow tumor cells to multiply endlessly, right? So mutation occurs. And the result is endless mitosis. Associated with that endless mitosis, we're also going to see, and this will account for some of the symptoms that we'll talk a little bit about. there's going to be some angiogenesis. There's going to be failure of apoptosis, failure or avoidance, pro-growth, signaling molecules. So you know what we're talking about when we say that. We're talking about the growth factors and the growth factor receptors and that sort of thing that we've spent time talking about. So that's what we mean there. And suppression of anti-growth. So in other words, the regulation. And then we're going to see in the more advanced stages, spread. In other words, metastasize. So for all of this to occur, clearly what has happened is we've activated of oncogenes and we've suppressed tumor suppressor genes. So for example, about half of all lung cancers have abnormal P53. Remember, P53 was our tumor suppressor gene. So in about half the cases, the P53 is a part of the etiology. Remember, P53 was going to interrupt or delay mitosis. It was going to initiate repair. And if those things failed, then it would induce apoptosis. So about half of all lung cancers have abnormal P53. And that results in the impaired function of those three factors that we just mentioned, and sets the stage then for the points that we've put down here. Another gene that is implicated in lung cancers, some of the lung cancers at least, is the endothelial growth factor receptor gene. It's stimulated by the epidermal growth factor. It's proto-oncogenic. If it mutates, it's going to cause abnormal activation of the growth receptor so that it binds to growth factors even when the growth factor is in low amounts. Or it basically means that these receptors are constantly on even in the absence of the signaling molecule, the growth factor itself. So some lung cancers have it's as high as 40% of these lung cancers. The most common type of lung cancer, about 40% of those will have abnormal EGFR genes. So plus or minus 40% of what's called an adenocarcinoma in the lung has abnormal epidermal growth factor receptor genes. Therefore, the EGF receptor is on. And when it's on, it's promoting growth from within the cell. Remember, these receptors are transmembranous receptors. They are binded to typically by the growth factor on the outside of the cell and activate intracellular mechanisms on the inside, second messenger mechanisms. So in this case, those second messenger mechanisms are always triggered to be on, promoting growth and mitosis and that sort of thing. So that's, again, setting the stage for multiplication of cell numbers. Let's see here, what do we have? So here we've got a picture of a lung or a pair of lungs. Just to orientate yourself a little bit here, I got a right lung and a left lung, the trachea. There's lymph nodes along the pathways of the largest airways, the largest parts of the trachea and the bronchi. And these represent more of the common locations for tumors. In some cases, the tumors grow on the outside of the airway, and as they get large, they start to block by encroaching or pressing on the airway, and that's where a lot of the symptomatology will come from. If they are internal within the airways, then they block airflow outright, and the distal segments beyond the blockage will not be able to receive air or expel air. So the respiratory mechanisms will be interfered with, and that's where a lot of the presentation will come from. So what do we expect with respect to what we've talked about? What are we going to expect in terms of signs and symptoms? Again, it's an airway, so think about it. Very early, there may be no signs and symptoms because airways are numerous and some compensation can occur. But also keep in mind that the cell numbers are relatively low. From there, we'll see some progression. It's sort of a non-specific presentation, a cough, maybe a little bit of noise or a little bit of discomfort with breathing. So the general term for that is dyspnea. That would be DYSPNEA. And maybe a bit of chest pain. So again, this is a bit of progression. As the cell masses start to increase, they're going to apply pressure to adjacent tissues and create some symptomatology that way. Eventually, the cough may produce blood, which is a factor of the angiogenesis and or the invasion of cells breaking through basement membranes of other cell tissues and breaking blood vessels, may be indicative that metastasis is occurring. But early on, it's more about invasion of local tissues and the poor characterization of the new blood vessels that are forming during angiogenesis. And then we'll get some loss of appetite, some weight loss, weakness. Again, somewhat general in terms, but this is all otherwise known generally as cachexia, what we mentioned in the previous lecture. Maybe some fever once the immune system is activated due to infection. Remember, the respiratory airways are designed to be sterile. So now we have a mass in there that's creating a disruption of gas exchange. It's changing the environment. So there's a chance that, especially with breakdown of local tissues and so on, that there'll be some inflammation. and that may activate white blood cells to create some fever. Night sweats is a little bit of a clue that something ominous is going on in the absence of a typical infection and that sort of thing. The airways may become obstructed. And again, or the mass can press on local tissues. It might press on the phrenic nerve, which supplies a diaphragm, and that will interfere with breathing. It may press on the inferior vena cava, the major vein that drains the systemic circulation from below the heart. And in that case, it's going to interfere with cardiac function. So these are all concerns we have. The nerve to the larynx that may then present with a hoarse voice, a raspy voice. Now, by the time you get to a diagnosis, about 1 of every 3 show metastasis. At diagnosis. In other words, it's quite advanced at diagnosis. And the most common place for metastasis to occur in lung cancer, although it's pretty variable, is to the brain, and often to the bone tissue. So in that case, it can present itself, for example, in the pelvis or in the clavicle, maybe in some of the vertebrae, causing back pain. And then again, another location that's relatively common for lung cancer is to the liver. So there's 3 relatively common locations for metastasis in lung cancer: brain, bone, and liver. Sounds a little bit like a potential for a multiple choice question to me. So keep in mind that sometimes, the tumors that are growing in the lungs may be asymptomatic, and it's the metastases that give presentation early first. So for example, if it metastasized to the brain, it may present as a headache or nausea, because remember, the vomiting centers are located in the hypothalamus. Maybe there'll be seizures associated with it and that sort of thing. If it's in the liver, there could be abdominal pain, upper and right-sided quadrant pain. It may be some swelling or pressure in the right upper quadrant due to an increase in size of the liver. If it's bone tissue, typically it may lead to fractures if it results in weakening bone tissue or bone pain. A sort of a diagnostic to keep in mind is that night pain, in the absence of daytime pain, but night pain that feels deep and non-specific, or in some cases feels like it's in the bone tissue at night, that's an indicator, not a guarantee, but it's a pretty good warning sign that patient may be dealing with a metastasis of some sort of cancer. So unexplained night pain is a big warning sign that you might be dealing with a cancer. I mentioned this earlier too, that oftentimes in the lungs, these tumors relatively often release hormones, produce and release hormones. So remember, we call that a paraneoplastic syndrome, or a paraneoplastic presentation, because it's going to present with the symptoms of the hormone changes as opposed to typical ones of cancer. So I mentioned that you could have a tumor that produces a parathyroid hormone related protein. In that case, the result is going to be increased levels of blood calcium. Another type will release ACTH. ACTH is part of the pathway that results in an increase in cortisol. We get an increase in cortisol, blood glucose goes up, um, and cortisol levels goes up, so your immune system is inhibited, or it is compromised, and you may be more prone to infections and that sort of thing. Another type in the lungs produces ADH, and as a result of that, we can dilute the sodium in the extracellular fluids, so you end up with hyponatremia. So again, the diagnosis initially might be somebody that has an electrolyte imbalance, but in reality, it's being caused by a tumor in the lungs. So these are all things that have to be worked through with respect to a diagnostic and considering, differential diagnoses. So given the variety of presentations, diagnosis is tricky, and we're going to need some help. So always, it's important that a diagnosis includes a very thorough history and physical exam. In the history, you want to go through, generally, especially at this point, somebody's got a cough or somebody's got a fever, and maybe some weight loss. You're not really sure what it is you might be dealing with. So asking the right questions and listening to the answers becomes really, really important in healthcare generally, but particularly when you're trying to work your way through a complicated presentation. Complicated maybe because it's vague. So you need to consider all of these things. Now, once you've got past that and your index of suspicion is heading you towards the possibility of lung cancer, one of the gold standards is an X-ray, because we can X-ray the lungs, and oftentimes what a tumor will show up as on an X-ray of the lungs, a standard X-ray of the lungs, is a cloudy or dense area in the lung tissue, where lungs, as we know, are kind of spongy. So they're filled with lots of air sacs, the alveoli, which shows up on an X-ray as clear. If there's scarring and thickening of the tissues around those areas, in this case because of a tumor of some sort, then there's going to be indicators on a standard X-ray that will give you some location and also the extent of the tumors. So you may see multiple clusters of cloudy areas indicating densities within the lungs. Now they haven't, that's not diagnostic of a tumor, but it is going to be helpful towards your diagnosis. So you're looking for densities, and that's going to help you with location and with extent of the tumors. Is there more than one? Are there too many to count? That sort of thing. So that's where a standard X-ray is going to help. It may also show that a lung has collapsed. If the air on the other side has been depleted because of a blockage, that lung may collapse. Or you may see some shifting of lung tissue and so on, because some part of the lung is inflating and another part is not. So basically, that's going to give you an increased index of suspicion if you start to see some of these cloudy or dense clusters within the lung tissue. A CAT scan is more specific. It gives you more differentiation between soft tissue. X-ray basically is designed to show bone tissue because it's mineralized, and it shows in quite good detail, the edges of a bone and whether a bone is interrupted, fractured, that sort of thing. And soft tissues tend to be more cloudy and a little bit diffuse. But a CAT scan is going to give you much more specificity for size and location and things like that. So we'll just summarize that as being more specific. So the definitive test is the biopsy. So if you found a cloudy spot on a standard X-ray, it may require an intervention where a biopsy is going to be taken. So the biopsy is going to literally be much more invasive than an X-ray would be because it requires interrupting the skin and pulling out a segment of that density for examination. There's another test that's available that's called they call it a PET scan, but that's stands for a positron emission tomography. Whoops, let's take that part out. So that's what the PET is all about, the P for positron and emission tomography. And that's an examination that will show up metastasis in the body. This is a sort of a scan over the whole body, and it shows hotspots. It shows areas where really angiogenesis has occurred, indicating that there's increased metabolic activity in those particular locations. Screening can be controversial, and we'll talk about why that is in a few more minutes. But screening can be a valuable tool. It can improve an early diagnosis and also prognosis, because as we know, the earlier the diagnosis, then the earlier treatment can start, the better the prognosis is going to be. So basically, screening would be applied typically to populations that are known to be at higher risk. Maybe there's a family history already. It's an older individual, it's a smoker. But the issue with screening in any case is that it does increase the risk for what is called a false positive. So a scenario where the screen is done and suggests that cancer is present when in fact it isn't. So it's called a false positive test when that happens. And the screening is radiation exposure, which can actually cause or aggravate, can cause DNA mutations and create a cancer in some cases. So in Canada, current and former smokers might be considered for scanning, but it would be based on the degree or the amount of smoking, and there's a measurement that's out there that they refer to, and they refer to pack years of smoking. So in an age group that's pretty specific, somewhere, for example, I'll just tell you that the Canadian standard for a screen for lung cancer would be in patients that are 55 to 74 years old and 30 pack years of smoking. So a pack year for smoking is the number of packs smoked per day times the number of years someone has smoked. So if you smoked one pack a day for 1 year, that would be one pack year. If you smoke 2 packs of cigarettes for 6 months, that would also be equivalent to one pack year. So if somebody has had 30 packs, 30 pack years, they might have 1 pack a day, but they've had that for 30 years. Or they could have 2 packs a day, but for 15 years. That would be put you in the category where your physician might suggest a screen because you've got a nagging cough or you've had some weight loss that can't be explained for another reason. Okay, now when we look at treatment, it's going to depend on the location, it's going to depend on the cell type, It's going to depend on the patient's age. It's going to depend on their overall health. Um, if it's an early diagnosis, then surgical removal is a major consideration. Otherwise, you're also going to recruit chemotherapy and radiation therapy. Later the stage of cancer, the more likely that radiation, chemotherapy, and targeted molecular therapies are going to be applied. Early on, surgical removal, because by definition, if we're early enough, the abnormal cells are still within the tissue of origin. So we can go in and we can take a section of the lung out. Remember, we said when we talked about surgery as a treatment choice, that you would also take a border around of healthy tissue away. The good news is with lungs, that the lungs are kind of overbuilt. So you can take a section of the lung out and still have good oxygen and carbon dioxide exchange going on to maintain a decent quality of life, assuming those other factors apply. Otherwise, good health and those kinds of factors that are going to improve your chances for survival. Surgical removal when early. And then we're going to add chemo and radiation as required. Later, we may if it's more involved, if there's been some spread or it's a relatively large area, then we say later stage cancer is going to involve those things: radiation, chemo, and molecular or targeted therapy. So again, remember from the last lecture, when we talk about molecular targeted therapy, we're looking at proteins or hormones or enzymes that are part of the pathways intracellularly that are promoting this unchecked multiplication of cells. So we can interrupt those multiplications of cells. That often is going to allow us then to get p53 involved naturally and other suppressor cells to be able to sort of catch up with the multiplication of the cells that have been a bit out of control up till that time. In patients who are more advanced, the only option in some cases may be what's called palliative care, which is scenarios where lifestyle changes are applied to reduce the signs and symptoms and try to reduce the discomfort. So in very late stages, metastatic stages, what would be typically classified as a stage 4 cancer, where prognosis is not very good, the goal then is just to try to make the patient as comfortable as possible. So that would apply to late stages, including metastasis. Prognosis for patients who have been diagnosed with lung cancer varies, of course, by the age of diagnosis and so on. So earlier the diagnosis is a better prognosis. That's really a standard statement for any type of cancer. You could make a point of saying that the earlier the diagnosis for any disease typically is going to increase prognosis. So lung cancer's got a pretty high mortality rate. So the earlier the diagnosis, the better the prognosis is going to be. Somebody who has stage 4 lung cancer basically has a 0% 5-year survival rate. Those that are diagnosed early in their diagnosis are going to have a anywhere from a 20 to 50% 5-year survival rate, depending on just how early it is. If it hasn't spread and it's still within a localized area and can be surgically removed, the prognosis is much better. So keep in mind that one of the more common etiology causative factors for lung cancers is caused by smoking, and one of the most common DNA changes that occurs as a result of the exposure to smoking is abnormal p53 suppression. And as a result, we get minimized repair opportunities, we don't slow down mitosis, and we avoid apoptosis. So that's in more than 50% of those cancers found in the lungs on a typical basis. So again, this p53 as a tumor suppressor is extremely important, and this is a great example in lung cancer. Okay, let's look at another cancer. Let's look at prostate cancer. The good news for females is that they can't get prostate cancer. Prostate cancer is going to be unique to the prostate gland. Females don't have a prostate gland. Recall that the prostate is a gland found in the male reproductive system. It's inferior to the bladder. It contributes to anywhere from probably in the vicinity of 30 or 40% of the seminal fluid. That seminal fluid is filled with citric acid, among other molecules that are designed to support motility and viability of sperm in the male reproductive system. So generally speaking, this 20 to 30% volume that's the responsibility of the prostate gland is very, very important to a normal reproductive functions for a male. So this prostate cancer is the second most diagnosed cancer in males. So from a diagnostic point of view, it's a very common cancer to be diagnosed. Worldwide, it's the 6th leading cause of cancer death in males. But in Canada, it's probably the #1 cause for cancer deaths, because we have good management of some of the other cancers, and as a result, this one has a very high mortality rate. So it makes it significant from a diagnostic point of view that we get at this as early as we possibly can. Lung cancer has a higher mortality rate, but that mortality rate is based on both males and females. When you look at the percentage of diagnoses versus mortality rates, it puts the prostate cancer up very, very high. 68% of males will develop prostate cancer by the age of 80. So it's almost inevitable that the older you live, the more likely there is that you're going to have a diagnosis of prostate cancer. It tends to grow very slowly. So depending on the age of onset, treatment will vary. The average age at diagnosis is around 70 years of age. So prostate cancer has a high mortality rate. So it's diagnosed as the #3 cancer overall, but #1 for males in Canada. And it's got a relatively high mortality rate, so it's got to be considered the third highest cause of cancer death in North America for males. So that's to put it into perspective. The #1 is lung, which we've already talked about, and #2 for cancer is colorectal colon cancer, which we're going to be talking about a little bit later. So number 3 for causes of death by cancer in North America. And to put that into perspective, number 1 is lung, and number 2 is colon cancer. Just so we're clear, though, we're talking about cancers here. So it's a major cancer, particularly obviously for males. And the earlier a diagnosis, the better the prognosis. And our diagnoses rates went up with the screening of PSA. So PSA is produced in the prostate gland. It's a type of lytic enzyme. It's called a proteolytic because it breaks down. PSA is known as a proteolytic. It breaks down proteins. Proteolytic enzyme. So it's part and parcel of the product that's produced by the prostate gland. And if it's elevated, it's an indicator that there are tumor cells producing extra PSA. So it's a sign that there could be a prostate tumor under those circumstances. So if PSA is elevated, it indicates tumor. Now, again, as always, with any kind of a screening scenario, there's always the risk of false positive diagnoses. So that's always a concern in the healthcare system, because of course the implications are a patient is being told they get a cancer when in fact they don't, because people may have an elevated PSA for another reason. Your PSA levels can go up because your prostate gland is swollen, which is also something that happens with aging. In men, is they sometimes get what's called a benign hypertrophic prostatitis or prostate gland. And in that case, the gland has gotten bigger, but it's not tumorous. It's not a cancer. It won't metastasize or anything along those lines. So when we talk about the pathophysiology of prostate cancer, the most common mechanism behind that pathophysiology is basically a scenario where small clumps of cancer cells initially are localized to the prostate gland and will proliferate and be promoted through progression, those terms we've used with respect to cancer, to spread to local tissues first, nearby tissues first, and then through enzyme activity, possibly metastasize through the bloodstream to more distant sites. So one of the mechanisms that we know happens in prostate cancer as part of that pathophysiology is a mutation to a tumor suppressor gene. So it's a mutation to the tumor suppressor gene for a protein that's called ZIP. You'll see why the ZIP, specifically a subcategory ZIP1 protein. So ZIP1 protein basically regulates active transport. So this is what its responsibility is. Active transport, remember, active transport requires energy, of zinc into the prostate cells. And zinc, normal functioning for zinc is that it's anti-proliferative. In other words, it's going to inhibit the reproduction or multiplication of these cells, and it promotes apoptosis. So this is what it does under normal circumstances. When we look at the contents of prostatic fluid, the contents include these proteolytic enzymes. One of the most numerous or largest component of that is abbreviated as PSA, immunoglobulins and citric acid, but zinc is a big part of that. So typically zinc is going to be accumulated by the prostate to help produce that citric acid. We need zinc to produce citric acid. So we've got a gene that directs a protein, ZIP1 protein, specifically for the transportation of zinc into the prostatic cells so that they can produce citric acid. So we like zinc for all those reasons. Not only do we need it for the citric acid, but it's anti-proliferative, suppresses, and increases apoptosis. So again, the prostate cells under normal conditions would be relatively low in zinc without this ZIP1. So if this ZIP1 becomes abnormal, if the suppressor gene is inhibited or altered so that it cannot promote uptake of zinc into the cell, then we lose the anti-proliferative part, the suppressor part of the regulation of that cell cycle, and we lose the ability to initiate apoptosis if those cells become abnormal. So this is one of the major genetic pathways that are altered during prostatic cancer. One of the things we also know is that, so this is sort of responsible for setting the table for the early onset and the early pathogenesis of prostate cancer, and then later P53 becomes abnormal. So it's not responsible really for the early changes, but does become part of the later changes, more advanced factors in prostatic cancer, and it's probably the key to metastasis in cancer, prostate cancer. Later, P53 becomes abnormal and leads to I just want to be careful when you're reviewing this that we understand that what we're really saying here is it's not the only thing. So it's a factor that leads, oh, I didn't leave enough, that leads to metastasis. So it won't be the only thing. It's not a guarantee even that it happens all the time, but the idea is that if P53 becomes abnormal during the progression of prostate cancer, that's an increased likelihood that metastasis either has already occurred or is going to be occurring. Okay, that should be, I think, okay for everybody. All right, so what about a diagnosis? So well, actually, before diagnosis, we want to have some symptoms. So we better deal with some symptoms first, signs and symptoms. So when we look at signs and symptoms early on, just like we talked about with lung cancer, there's often no signs or symptoms. The cells are growing and multiplying, and it's going to require millions, if not billions, of multiplied cells before they're going to start to exert some pressure on nearby tissues. When that happens, there's going to be some presentation that typically affects the urinary system. It's most noticeable in the urinary system. You're dealing with men that are older, so it is probably going to be less recognized as a problem with the reproductive system as it is to do with the urinary system more commonly. So basically, it'll progress from no symptoms to an increase in frequency, maybe getting up more frequently at nighttime. Almost every adult male and female starts to get up more often in the evening at nighttime. May have a problem with starting or the initiation of urine production, and then maintaining. As it advances, there may be some blood in the urine, known as hematuria. And again, as it starts to advance, particularly if metastases, you may start to see some systemic presentation. So the fatigue due to some anemia or redirection of blood flow, angiogenesis. If it's metastasized, again, metastasis from the prostate gland, it's relatively common to end up in bone tissue. So there may be some bone pain that might present as that night pain that we talked about when we talked about lung cancer. During the late stages, when metastasis has definitely occurred, that's where the bone pain is most likely to present. Near the prostate gland are going to be the lumbar vertebrae, the pelvis, and possibly the ribs. So vertebrae. So when we talk about metastasis in the prostate gland, the most common locations are going to be bone tissue, before we would see it in some of the other tissues. And the mode of passageway is often going to be through lymph nodes. There's lots of lymph nodes in the pelvic region, so there's lots of potential for invasion into those lymph nodes and pathways through the lymphatic system. Who's at risk? Now, obviously, the biggest risk factor when we talked about the lung cancers were smokers, but also people who have been exposed to chemicals like asbestos, like we mentioned. And then the odd time there's an unexplained reason for why some of the genetic changes that occur in lung cancer are initiated. There may be a familial hereditary factor that's not recognized just yet. But obesity is an underlying risk factor for almost every pathology. So you can put obesity and smoking as a risk factor for almost every pathology. We know that as you get older, that's going to be an issue. The more sedentary you are, if you're not sure what that means the less active you are, the more higher the risk. If there's a family history, there's an increased risk. And if you have a high blood pressure, you may be at increased risk as well. Diagnosis. A relatively non-invasive investigative tool is the rectal exam. Your care provider is able to palpate the prostate gland through the rectum and try to determine whether or not the size and texture of the prostate gland is within normal parameters. So it's also sometimes called a digital exam. The normal prostate is going to just be somewhere between 2 and 3 centimeters wide, with a slight protrusion towards the lumen of the rectum. In other words, should sort of bulge a little bit through the lumen of the rectum. It should feel to the investigator to be firm and smooth, with a little bit of a sulcus between the right and left lobes. It should be non-tender when palpated and have no palpable nodes associated with it. So that if it's hard, if it's rigid, if it's larger than what we're describing there, then it's an indicator that maybe some more invasive diagnostic, in other words, a biopsy, is going to be called for under those circumstances. So the rectal exam is to determine size and texture. Okay, and then you can scope it, cytoscope. And in this case, the cytoscope is you can take a look at the urethra from the bladder, and the urethra leaves the bladder and passes through the prostate gland. So if you can take a look at the urethra that passes through the prostate gland, if the lumen of the urethra is compromised because of a mass of cells that are pressing on it, that would account for the poor urinary stream and the inability to get started when trying to void your urine and that sort of thing. So the cytoscope is designed to take a look at the urethra to see whether there's encroachment on that particular structure. And then when we look at biopsy, just like it is for almost every cancer, it's kind of the gold standard, and it's the only way that you can confirm the cancer. So that if all the signs, an elevated PSA, a rectal or digital exam that indicates the size is increased, and that maybe it's tender to touch and it's hard rather than soft, and that sort of thing, are all indicators that maybe biopsy is going to be an important part of the progression of this investigation here. So what do we do for treatment for these individuals? Now, I mentioned that first you got to determine whether treatment is even required. Older males that have a low-grade tumor often don't need treatment. They wouldn't be candidates for treatment. One, because they're older. Low grade means that it's likely growing slowly. So the term that's often used for patients that are going to be monitored in this way is called expectant management. So in older patients with a low-grade tumor, they're going to be watched, which we called expectant management. So patients diagnosed at 80 years of age, the reality is, he's probably within his last 10 years of life. If it's a low-grade tumor, it's growing slowly, it's not likely going to be a cause for mortality. Now, if somebody needs a more aggressive therapy because of the stage or the age of the individual, there are removal techniques. For younger patients and later stages. And now, but before So surgery is going to be considered as long as metastasis has not been confirmed. So there are hormonal therapies and chemotherapies that can be applied if metastasis has occurred. These are typically medications or approaches that are designed to suppress LH, the hormone LH that stimulates testosterone production. So we know that one of the major genetic changes that occurs that's observed in those with prostate cancer, in addition to the ZIP1 that we've talked about already, are what are called LHRH. So that's luteinizing hormone releasing hormone agonists. So these are proteins that are released that stimulate luteinizing hormone. When you stimulate luteinizing hormone, you increase testosterone, and that's sort of a normal role for the luteinizing hormone in the first place. So the issue is that if the agonists are increased, then it's going to cause natural LHRH to be reduced, so that ultimately luteinizing hormone may actually decrease and the testosterone levels decrease. So in the first stage of a abnormal LHRH agonist production, you get an increase, then you get a decrease, and then finally what happens is the low levels of testosterone will slow prostate cancer cell growth. So that's why this becomes a treatment plan. If you can address the LHRH agonists and promote the functions of these LHRH agonists, you reduce testosterone production. And we know that in prostate cancer, elevated levels of testosterone tend to be promoters of the advancement of the prostate cancer. So that's a type of treatment that's designed to try to keep testosterone levels low so that the testosterone doesn't promote progression of prostate cancer. So you can actually outright remove the prostate by a surgery. There's a couple of approaches that are taken. There's literally the prostatectomy, where the prostate is surgically removed. Radiation can be used to destroy the prostate, so it kills all the prostatic cells, and as we know, may kill cells around that area as well. And then there's another approach that's referred to as cryosurgery, where the prostatic tissue is frozen to especially targeted at the abnormal cells, to sort of freeze or kill the abnormal cells through the freezing technique. And sometimes ultrasound can be used. Ultrasound is mechanical, so it will agitate the cells. I think I've got a picture to show you. Yeah, unfortunately, it's not a very big picture, but you'll be able to take a look at it at your leisure during the recording. So there's our prostate gland. You can see it leaves, at least the urethra leaves the bladder and is going to become part of both the reproductive and the urinary system as it passes through the penis. If we do an enlarged view of the prostate, cross section here, you can see the prostate surrounds the urethra and surrounds the ejaculatory duct component of the reproductive pathway, and then they join together in the prostate. So here's our mass. Here's our example of a mass that grows. This one would be considered in situ. In other words, it's still within its original tissue or cell group of origin. So it's a nice prime target for a surgical removal because it's within its original tissue, and it's an indicator with that border. I mean, I just blackened out the border, but it was relatively well demarcated. So it's a candidate for surgery, and it's not yet applying pressure against the urethra. So theoretically, this individual would not yet have urinary symptoms because it hasn't applied a pressure to the urethra. But you can see that if it were to continue to grow, it would begin to encroach on the urethra. and would interfere with normal urinary release pathway through that location right there. And again, it also provides a nice target for one of these other techniques like radiation and or cryotherapy. If you're not sure, cryo is spelt cryotherapy is an indicator that you're using ice or low temperatures, in this case, to kill cells that are otherwise a concern. So what's our prognosis? Somebody who has cancer, prostate cancer in particular, we've kind of indicated that it's going to be stage dependent, of course. So prognosis, most men won't die from prostate cancer, depending on the age of diagnosis. Basically, the older they are and the slow growth type of scenario indicates that they'll die from other factors before the prostate cancer will metastasize. So basically, the older someone is, the 5-year survival rate is somewhere in the 30% range. If it's localized, like the one I showed you in that picture, if it's well localized and can be removed, then the 5-year survival rate is closer to 100%. The higher the grade and stage, the poorer the prognosis. There is a scoring system that's unique to the prostate gland. It's basically a grading system, but it's unique to the prostate gland. So it's called the, so we'll just say early, no metastasis, plus or minus 30%. These are not percentages I'm going to ask you questions on, but just for points of reference more than anything else. You'll find depending on the source you use, these stats would be a little different anyway. So that's another reason why I don't like asking those kinds of questions. If it's an earlier diagnosis and there is metastasis, so we'll just abbreviate that as METS, then the prognosis isn't quite as high. So now I gotta clarify this. So it's early onset, early diagnosis. Now let's just take all of this out, just to mix everybody up completely. So when it's an early diagnosis, the 5-year survival rate is about 30% if there's metastasis. So 5 years later, 30% of those that had METs would still be alive. It's closer to 100% if there's no metastasis. So in situ, it's more easily removed, that sort of thing. So as the grades progress and the staging gets later, the poorer the prognosis. This screening, this Gleason grading system or Gleason score, it's a grading system, kind of like the one we talked about, but specific to the prostate gland in this case, probably designed by somebody named Gleason, basically says you can have what's called a Gleason score of X, no determination. You can't determine a score, maybe because there was an elevated PSA, but there's no other indicators that are pointing towards cancer. It may be that it's still microscopic and not detectable, but at that point it would be something that would be watched but not acted upon. You can have a low grade, which in the Gleason scoring would be a Gleason 6 or less. So the cells look pretty normal. There's still some differentiation, and they're still local to the prostate gland. So moderate, your Gleason score would be a 7. So that's right smack in the middle. And that's where you start to see, so there's still differentiation and local. So now we're seeing less differentiation. And then when we look at a high grade, that's a Gleason score that's greater than 8. And typically goes up to a 10. That's got there's poor differentiation. And there's a higher indication that in that scenario, up in that grading, that there would be some metastasis.